This study is an attempt to look at systems challenges within our hospitals. And so it's not an epidemiological study. We're not looking to measure the amount of diagnoses or mental health problems there. We're looking to identify mental health cases on our pathways. So we try to cast the net wide and look in as many hospitals as possible, and almost 200 hospitals across the country took part. We looked at a window of time over 2 weeks in 2014, and we identified 5 cases from each of these hospitals.
They were anonymized and reviewed by case reviewers. This is a group of clinicians drawn from all hospitals again across the country and included physicians, surgeons, liaison psychiatrists, liaison psychiatry nurses, and other members of the multidisciplinary team that may be involved in looking after patients who have both mental and physical health conditions.
What goes through the mind of a physician or an acute trust nurse when a patient with a comorbid mental health problem arrives?
While most general hospital staff are quite skilled and trained in looking after medical emergency or surgical emergencies, they may not have the knowledge or confidence in looking after a patient who also has a severe mental illness. And I think that comes through in the report, just as we think. We did find that although 2/3 of the patients arrived through the emergency department clearly had a severe physical health problem, not all of them had their mental health diagnosis recorded when they came into hospital. Soon after admission, they have been assessed, and again, their physical health condition usually is assessed quite thoroughly and quite promptly, and probably treatment started on time, as well as the investigations. But the same type of focus is probably not given to their mental health condition. And we find in the report that the number of patients who were referred to liaison psychiatry right at the initial assessment in the emergency department was around 55 patients, but the case reviewers felt another 55 should have been referred at this stage.
It's very interesting listening to your thoughts on the challenges that exist, because one of the major ways in which both government policy and a whole range of hospitals have pursued addressing these challenges is the establishment or expansion of further liaison psychiatry or mental health liaison services across our hospitals. And we see within this report that the presence of a mental health liaison team certainly helps to address many of these challenges. But there's also something more than that as well, because it's not just about a specialist team coming in to give advice or to help co-manage, important as that is. But there's also something about trying to ensure that general hospital staff who are looking after the patients for the vast majority of time also feel much more skilled in being able to deal with these comorbid challenges. From a mental health liaison point of view, we see peppered throughout the report a series of challenges to us as liaison psychiatrists to do things better. There are a substantial proportion of patients for whom there's a delay in referral to our service, and I think that can come about because the treating hospital doctor thinks that there's no need to, or that there is perhaps a culture of a liaison service not coming until people are seen to be medically fit, which is something we really need to try and reduce significantly, because this report is one of many which is pushing towards this notion of parallel working and joint management.
Discharge planning is always difficult if you're dealing with a complex patient. And here we have additional complexity in terms of also having a mental health condition. And I think the theme we've had through the report stands out again here, that when we are planning discharges, we tend to focus again on their physical health condition and don't pay as much attention to the mental health conditions. For example, we found in this report that almost 50% of patients did not have adequate discharge planning, when they were leaving hospital. About a third didn't even have their mental health condition recorded on the discharge letter. And then roughly an equal number did not have their mental health medications noted on the discharge letter. And to top it off then, of course, almost no discharge summaries were copied to the mental health team, definitely not to the responsible mental health consultant.
I suppose this feeds into the fact that the way in which we run our healthcare providers means that mental health care is often run by different organisations, especially in England, with different record systems and different ways of doing things. And so if there isn't this assertive and purposeful exchange of information, then stuff is often missed.
That's true. Yeah.
So the vast majority of hospitals who responded and took part in the report had some form of mental health liaison team, which is great. But a substantial minority of them still had problems around either the time in which that mental health team was available, with approximately half not providing 24/7 care, or the space in the general hospital that was actually covered. A substantial minority of the hospitals that have a liaison service are plan accredited, with another substantial number aiming to become plan accredited. And this is really important because this is a quality assurance program run by the Royal College, and we see in the overall quality of care at the end that if your service is plan accredited or moving towards being plan accredited, then the overall quality of care is seen as being higher.
What do you think about the key findings around dealing with challenging patients in general hospitals?
Yeah, I think these can be incredibly stressful for our workforce to deal with, as we see throughout the report. In the number of incidents that we have in the report around refusal of care or people wishing to leave when the treating team think they shouldn't. And of course, this highlights the big problem that we've got in our services, where people are either feeling that they have the knowledge or the skills to deal with either physical health or mental health, and not both of them together. Of course, at its most extreme, it also results in security staff being called to deal with some of these challenging situations, as we saw in the report as well. 23 out of these cases had security involved, which is obviously, highly distressing for the patient, but also incredibly challenging for our teams to deal with as well. So from a training perspective, Vivek, what do you think the challenges are around mental health issues in the widest possible sense and general hospital staff?
I mean, if you look at the comparison between physical health conditions, if somebody was admitted to the general hospital that needed a specialist input from a physical health point of view, there would be a group of presentations that we would manage ourselves, but also be very clear about when we need to call in the relevant specialists and what kind of support they would provide us. And I think when we carry that over to a patient's mental health condition, firstly, the knowledge and skills to manage the common presentations, I'm not talking just about diagnosis, but presentations in these patients, we probably don't have the confidence, probably because not enough training has happened, to deal with those presentations. So we probably call you too early, but also sometimes we probably call you too late because we don't know when to do that. Now, we did carry out a survey of general hospital staff as part of this study. What was reflected in that?
Yeah, and I think the findings from that survey are reflected in everything that you've just been saying. There are a substantial proportion of both senior doctors, doctors in training, and nursing staff who haven't had even basic mental health awareness training, let alone training around some of the more specific areas that are required in a general hospital setting. And I think this highlights the need for much of this training, both in terms of e-learning, classroom learning, and simulation training, to actually expand skills for our general hospital staff to improve their to improve their knowledge, but also their confidence in being able to deal with these issues better.
This report had 22 recommendations which cover the whole patient pathway right from admission to discharge. The recommendations are agreed by the members of NCEPOD, those who have contributed to the study, and the wider stakeholder group that is involved with NCEPOD. There were 6 principal recommendations that I think everybody needs to take away from this report.
Absolutely, but the overall arching theme very much from all these recommendations is the necessity for all of our teams, whether in a general hospital setting or from a mental health liaison point of view, to work together much more closely, which is why we named this report as Treat as One.
Yes.